When the COVID-19 crisis really came to a head, there were certain management issues put into place, but we saw very quickly that we'd have to prioritise quite a few patients, particularly our older screening patient cohort. But essentially, the abundance of patients who are post-menopausal in breast cancer terms, they constitute the majority of patients. So we needed a way to sort of sort through which of these patients should be done soon in terms of being operated on, and which could be perhaps put on endocrine therapy, a tablet basically that could essentially put them in a holding pattern and would be actually effective against their cancer and potentially even shrink their cancer over several months. I knew that Mitch Dowsett had done a lot of work around this area, and so I spoke to him and we had a discussion about how this could happen and what tests we could use. And Mitch's claim to fame worldwide really is his use of the Ki67 marker, which is a marker of cell proliferation. In a recent study presented a couple of years ago at San Antonio, the POETIC study Marsden led showed very clearly you could predict which patients would be resistant to endocrine therapy and have a greater chance of recurrence despite endocrine therapy. And Mitch decided to have a look at that study's data and also try and pull together other studies that had been done with similar information. And what we ended up with and what Mitch really went away and then gathered was really very exciting, because he showed that just with the simple use of receptors, and these are the estrogen and progesterone receptors, for which every patient's initial biopsy gives us a result. This is a standard result. This is nothing special that we do in particular centres. Everyone and every centre across the NHS will deliver these results on any diagnostic biopsy taken for any cancer patient. And so these hormone receptors, Mitch showed, could in themselves predict to a significant degree which patients might be very safe to leave on endocrine therapy, drugs like letrozole or aromasin, which are aromatase inhibitor drugs that reduce estrogen production and therefore starve the cancers of estrogen, versus those patients who maybe didn't have such strong receptor positivity. Now, what do I mean by that? Well, the receptors, estrogen and progesterone receptors, are scored, and they're given a score based on the percentage of cells seen in the biopsy under the microscope that stain up for these hormone receptors and indicate their hormonal sensitivity, which would then be blocked by these medications. Or they show up the intensity as well as the percentage. So there's a score based on two features: the percentage of cells that stain for these receptors and how strongly each cell stains. And by putting these together, we then get a score. In the UK, we use what's called the Allred score out of 8. And basically, if the score is 8 for each of these, in other words, close to 100% of the cells show receptor positivity, we know that it's pretty safe to leave patients by and large on this letrozole or similar aromatase inhibitor therapy for several months, and that it should be effective. It's in patients where the estrogen receptor is less than 6, for example, a score that's lower than, say, a 7 or 8 out of 8, that we should be thinking about surgery, and particularly for those who are under 6, so 5 and below, we should be very careful about, because those patients potentially have a very low percentage of estrogen-positive cancer cells within their cancer. And we must remember that cancers are not a homogeneous mixture of the same cells. They're not sort of clones. We know now that cancers are very heterogeneous in terms of their cell populations. And so this is likely to demonstrate that these cancers are more heterogeneous and that only some of the cells will respond to endocrine therapy. and some will be resistant from the outset. And so these are the patients we should consider either advising to go ahead with surgery, or if certain other criteria are met, maybe chemotherapy is a better way forward for some of those patients. So they're the highest risk group patients. And then somewhere in the middle, if you have a score, estrogen receptor score of sort of 6 or 7, not quite the 8, but not so low that we need to go immediately to, say, surgery or chemotherapy, then we've got that intermediate group where we want to ask further questions. And this is actually where now we're looking into this patient group in more detail, because they're the ones Mitch's algorithm would suggest that if we look at the Ki67, that's the proliferation marker I mentioned earlier, and we look at the Ki67 on that diagnostic biopsy, that is the biopsy taken before the patient started any treatment, we can already narrow down those patients and sort of, if you like, triage them further and prioritize them into one or the other groups, the high risk or low risk groups, just by seeing if that baseline Ki67 is a certain figure. And for example, we talk about 15%. So if less than 15% of the cells are actively seen under the microscope to be proliferating, or if you like, dividing actively, then we know we can sort of push those into the group that could have letrozole or endocrine therapy for a few months, and it would be safer to do so, because we know that if your baseline score and, if you like, cell turnover is already slower, then you've got a greater chance that you'll respond to the endocrine therapy. Whereas those with a higher proliferation rate at the very start, we then recommend that those patients, and this will be a small group, maybe 1 in 5 patients or even less, should then have a repeat biopsy on treatment. And this is exactly what the POETIC study, its basis was, the rationale for determining patients being in high, medium or low risk groups. So if you've got, for example, a high proliferation rate to start with, and you go on a few weeks of endocrine therapy, then within even a few weeks, and Mitch showed elegantly in his studies that even from 2 weeks onwards, you then repeat the biopsy, and if you can show that the proliferation rate, or if you like, the Ki67, has reduced below a certain amount, and in this case it's 10%, then we can be very confident that actually it's safe for that patient to remain on endocrine therapy, i.e. the tablets, for perhaps even up to 6 months. And that means that you know, these patients can then have surgery potentially delayed. And furthermore, we can give patients the confidence of this valuable information that we're basing this recommendation or this advice on very solid data that then supports this decision-making or this advice. Whereas those patients who, let's say, didn't respond to 2 to 4 weeks of letrozole or endocrine therapy, in other words, their proliferation or Ki67 remained high, and then we know that this group of patients may not really be suitable to maintain on that therapy, and they should really then be advised to have surgery sooner, or else chemotherapy in some cases. And I think as a clinician, to be able to be armed with that sort of knowledge in the background, and then to go to a patient and advise them with some scientific sort of rationale, empowers not only me as the clinician and other clinicians to do that, but then really, I think, gives the patient a higher level of confidence to listen to that advice. And this has, been highlighted in a number of patients. I mean, when this algorithm first started, for example, and we were in the middle of COVID, and Mitch did an amazing job getting this out in a very timely fashion, we at the Sutton end of the Marsden had kept a spreadsheet and had about, I immediately saw that there were 8 patients that could benefit from the algorithm and could be reprioritized. And to extrapolate this to, say, the rest of the RM hub, there are 3 hubs in London. The Royal Marsden hub, we could see that the Chelsea Marsden had about 10 to 13 patients who could benefit. And I'm sure that this is transferable not only across the NHS, but even really worldwide. It's applicable widely. And that's one of the strengths, I think, of this information. So, for example, I had a lovely patient in her early 70s who had a screen-detected cancer, and this was estrogen receptor positive. She was very keen on surgery and was quite distressed and found it distressing that despite the fact she was otherwise healthy, that there was uncertainty about when we could operate on her. By giving her this information and explaining to her that because her estrogen progesterone receptor status was 8 out of 8, if you like, or 100% for both receptors, that based on this algorithm, it was clear for me that I could reassure her that she could at least wait a couple of months on treatment with endocrine therapy and postpone the surgery, and that we could review things. And in fact, what we ended up doing was performing a repeat ultrasound in the clinic a couple of months later, just to reassure her that the cancer was not enlarging, in fact, and that it was safe to postpone surgery. On the flip side, I had a patient who was in her late 70s, and she actually had an estrogen receptor of just 6, but a negative progesterone receptor. And this sort of put her in the higher risk end of the spectrum of hormone receptor positive breast cancers. And so we actually contacted her within the unit and advised her to come forward sooner than we had expected, certainly sooner than she had expected, to come forward for surgery. And she successfully underwent surgery a couple of weeks later, and this was in mid-May, and successfully so, and was discharged without problems, and has now had a surgery and is having radiotherapy. And I think she was very relieved when she got the call, because although she had been sort of waiting in the background and prepared to have a review in clinic, I think in early July, she was delighted when we told her this news and to understand why we had advised her to come forward sooner, despite potential risks with COVID-19. So, I think one can see that, at both ends of the spectrum, this advice is very helpful. I think another aspect that, Mitch and his colleagues who led on this article were able to refine one of the challenges was to minimize the number of patients we'd want to call back for an on-treatment biopsy. In other words, a repeat biopsy at 2 to 4 weeks after commencing endocrine therapy to see if their cancer's growth rate had slowed down. In other words, was the endocrine therapy effective, and so could they stay on this? And as I mentioned earlier, by, if you like, inserting this possibility of a baseline Ki67 when the receptors were a bit equivocal, we could further triage patients without a second biopsy. And that was very important because it saves in the order of maybe 10 to 15% of those patients a second biopsy, hence a second visit to hospital and a second procedure. And so they even reduced that percentage of patients needing a biopsy to less than 1 in 5. And I think that was also a very elegant solution to the problem, which was, or the challenge, if you like, that COVID had placed on us. We estimated that through the hub, we'd have about 70 patients that may benefit from this. And there were a handful from the other trusts within the hub. And I think most of the trusts, pleasingly, didn't have such a backlog or such a large volume of patients that they were able to probably operate on most of them. But I think it really does help those trusts that have a large number of patients, and particularly high-risk patients. So just to put these patients into perspective, and I might mention too that at the time there were guidelines from around the world, including the Association of Breast Surgery in the UK and other peak bodies such as the Society for Surgical Oncology in the USA, that were coming out to help surgeons prioritize their surgical patients. And we know that there are young women with receptor triple negative patients, for example, they're hormone receptor negative patients. And those with patients who are HER2 positive, which is another subgroup of about 1 in 5 patients, that they were going to be prioritized towards surgery or chemotherapy ahead of this cohort of patients who are post-menopausal, as I mentioned. But within this group, as one needs to appreciate, this is a large group of patients. This constitutes about 70% of all breast cancer patients. So from a numbers point of view, it's a large number of patients. And whilst we may think of them as generally less urgent than some of the other subtypes of breast cancer, within this group we can see, and Mitch's algorithm highlights this, that within this subgroup of hormone receptor positive postmenopausal breast cancer patients, there's still a group of patients who are at higher risk and those who are at lower risk. In other words, some of them can wait longer, but some of them shouldn't and really should have treatment earlier. And that really was to work out which of those patients we could advise specifically to come forward earlier for surgery or for example, chemotherapy. So it was, I think, very helpful. In terms of the other trusts, most of those patients, I think, were able to have decisions made just based on their receptor status. But interestingly, in the last couple of weeks, we've just had requests from some trusts through Mitch's lab, who's providing Ki67 analysis, to do some more baseline Ki67s on patients. So clearly there is still, if you like, a need. And I think what we're going through now is the recovery phase from our initial COVID surge. And with new patients being diagnosed all the time, there is going to be a need, an ongoing need, if you like, to reprioritize these patients with, whether they need surgery in the nearer future or whether we can postpone them. So this problem is not going to go away with a lull in COVID cases or new diagnoses. And also, I haven't mentioned at all yet that whilst breast screening has been suspended and was suspended during the COVID peak, we haven't really seen a restarting of that screening process. And when that starts, we'll then get another surge of postmenopausal patients who fit into this group. And that will create further pressures, if you like, on units trying to deliver treatment. And furthermore, I think one shouldn't underestimate the psychological stresses this places on patients.